Hello, everyone, and welcome to the UHN Foundation's fourth virtual speaker series on movement disorders. I'm Christian Cote, host of Behind the Breakthrough, the podcast all about groundbreaking medical research and the people behind it at the University Health Network. We're grateful to you, our family of supporters, and so glad you're able to join us today. We hope you're staying safe and taking care of each other during these trying times of the pandemic. For today's live stream, we also want to give a special credit to Mr. Fraser Barrow. This movement disorder speaker series event is made possible because of his continuing generosity and support. So thank you again, Mr. Barrow. Today's live stream is all about another UHN first, the first interdisciplinary clinic in Canada dedicated to diagnosing and treating normal pressure hydrocephalus, also called NPH. NPH causes irreversible brain damage if it isn't diagnosed accurately and early. Problem is, NPH is often misdiagnosed because it has the same symptoms as many chronic and degenerative brain diseases, such as Parkinson's and Alzheimer's. So today we'll be talking to two pioneers who championed UHN's NPH clinic. Dr. Alfonso Fasano and Dr. David Tang-Wai are here with the story of how they recognized a gap in care for those with NPH, which affects 1 out of every 200 Ontarians over the age of 60. They'll also speak to how they came to create the NPH clinic at UHN, the amazing results they're now seeing with patients, and what's needed to sustain and expand the NPH clinic in order to keep up with the patient demand. Plus, we have a special guest appearance a little later in the show. Mr. Alan Lerman is a patient who is treated for NPH at clinic. He's going to speak to us about his experience. And as well, we want to involve you in the audience in today's discussion. So as you're watching the live stream, if a question comes to mind, please send it in. You go to the Slido page, and I think the link should now be at the bottom of your screen. Click on that link, type in the event code, which is MDS, hashtag MDS series, and enter your question. Please keep in mind, for privacy reasons, we won't be able to field anything of a personal medical nature. And we'll focus on your questions also a little later in the broadcast. First up, as always, we hand things over for an update to Dr. Anthony Lang. He's the director of the Edmund J. Safra program in Parkinson's disease, the Morton and Gloria Shulman Movement Disorders Clinic, and the Rossi Progressive Nuclear Palsy Center. Over to you, Dr. Lang.
Thank you, Christian. Hi, everyone. Good to have you join us again for one of these sessions. Those of you that have participated in the past will know that this is a way that we have of getting you familiar with the research that is going on related to our program and getting to meet the researchers and clinicians that are involved in the many facets of the programs that are affiliated with the Movement Disorders Clinic. A quick update, as with everyone, we're still in partial virtual care. A lot of our care is going on still with telephone calls and Ontario Telehealth, etc. We look forward to seeing more and more of you back here live for patient care. Although the pandemic has allowed us to become more efficient with virtual care, it also has caused us to realize where that falls short and how important it is to be regularly connecting live with our patients as well. Although it's been very convenient and it has helped our care, I think overall most of the doctors and nurses here feel that we give better care when we see patients live, but we can incorporate the virtual care into an overall program of patient care. So you get the best of both worlds that way, but we still feel that some live care is very important. And I hope you feel the same. We look forward to seeing you and interacting with you and your family members in a live way. As I said, these sessions bring you up to speed in many different areas, and I'm not going to deal with the details of all of the research programs that are going on. I would tell you that the Connect newsletter that comes out of our movement disorders program, the spring summer 2022, created and developed by Julie Rasiopa, our education lead, has just gone out. So hopefully most of you are connected with that availability. If you're not, please ask the foundation and they'll get you connected with our newsletter. And I think you'll all find that it's very, very well done, and informative. Today, we're going to hear about a condition called normal pressure hydrocephalus, as you've already heard. We see this because patients have gait disturbances, particularly in the movement disorders clinic, but that's not the only cause of problems that these patients have, as you'll hear from the two experts who have developed this program. The two people that you're going to hear from today are Dr. David Tang-Wai and Dr. Alfonso Fasano. Many of you have heard of from Dr. Fasano already, because he also is our co-lead for the Deep Brain Stimulation Program. And so he's already presented in this forum. The other person is an invaluable colleague, Dr. David Tang-Wai. He's a behavioral neurologist. So the people you see in the movement disorders clinic are largely movement disorder specialists. Dr. Tang-Wai is another kind of neurology specialist, a behavioral neurology specialist. And the reason he's involved is, as I've said, normal pressure hydrocephalus has many faces, many presentations, not only the walking, ambulatory, and sometimes Parkinson-like features, but also important cognitive changes. So there's a very good reason for a collaborative effort between behavioral neurology and movement disorders. So at that point, I'm going to thank you for attending. Hope that you learn a lot from this important presentation. Unfortunately, I have to go off and take care of patients. I have a clinic this afternoon, but I'm going to pass it on to Professor Tang-Wai to take over. David, take over.
Well, thank you very much, Tony, and good afternoon, everybody. I'm here to talk about normal pressure hydrocephalus and why it's important for us to understand this disorder and to look at it more closely. Oops, I'm trying to advance my slide. So here's the outline of our brief talk this morning between myself and Dr. Fasano. We're going to talk about, well, what is normal pressure hydrocephalus, or NPH? What are the symptoms of NPH? What do you really require to make this diagnosis? And why is it so difficult to make this diagnosis in real life? How common it is, what therapy is done, and what's special about the clinic that we have developed here at UHN. So, well, what is normal pressure hydrocephalus? But very briefly, this is a progressive neurological disorder where the spinal fluid, which is the fluid that accumulates in the brain, it's important for us to protect our brain and provide nutrients, et cetera. What happens is that it accumulates and it causes changes with our walking, our thinking, and our ability to control urine. And this condition can be helped with surgery. What are the symptoms? First, there's a walking change, a decline. And you could see on the video here a gentleman who does have NPH, and you could see the difficulties in standing up and trying to step and trying to walk. Then there's a change in thinking. And the most common symptoms of the change in thinking is this concentration, ability to multitask. That means keeping track of more than one thing simultaneously. Apathy is a sense of not wanting to do things, not because they can't, it's just I just don't feel like doing it. And sometimes that could be misdiagnosed or misconstrued as depression. And obviously there's some people who have short-term memory difficulties. And the other major symptom of NPH is this urine control. And in sequence, people develop changes with frequency, needing to go to the bathroom much more frequently. Then there's a sense of urgency. I need to do it right now. And then I can't get to the bathroom on time and I need to do it quickly. And unfortunately, they develop incontinence. And these symptoms develop slowly. They develop and change over years. And almost always, NPH is associated with a walking difficulty first. Well, what does it take to make this diagnosis? Well, we need an image. We need to have a brain picture, CT or an MRI, and we have an MRI shown here, where the ventricles, these large dark spaces that you see on this screen, become bigger. So that is absolutely required. Without that, it's probably not NPH. Then what I do is I do a memory test. I want to know where the strengths and weaknesses are in terms of memory or thinking, because that can help us decide, is this truly NPH or is there something else in addition or something else completely different based on how someone performs in a memory test. And a lumbar puncture, and this is a needle in the low back where we take about 4 tablespoons of 40 milliliters of spinal fluid to see, does walking improve before and after? And we watch the gait. This is Dr. Fasano's work where he will look at the walking before and after, and there's a video of that assessment. And we determine whether or not a spinal fluid, taking out the fluid, makes a difference in someone's walking. And what makes the condition difficult to diagnose is that there are a lot of other problems, a lot of medical problems, a lot of neurological problems that actually could have all three. You have problems with walking, problems with thinking, and problems with urination. And it is this combined effort that both he and I develop is how can we sort this out? How do we figure out, is it Alzheimer's or Parkinson's? Because there are a lot of mimickers. And with that, I'll switch it over to Dr. Fasano.
Thank you, Dave. Thank you, everyone, for spending your afternoon with us. I'm going to take it from here and explain a few things, particularly related to the epidemiology of normal pressure hydrocephalus, or in other words, how common this condition is. As you see from this slide, the median age at diagnosis is 70 years of age, so clearly it tends to affect seniors. The prevalence varies. It can be up to 6% of the population, but it depends really on the age that we are taking into consideration. So, for example, it can be affecting 1 in 200 adults over the age of 60. But if you look at the population of people above the age of 80, then you'll see that it can be as high as 1 in 20. On your right, you see a cartoon taken from a recent paper from North Europe, where they were looking at the incidence of this condition over time. And because of population aging, you can see that more and more patients are affected by this condition. And what is also interesting to report, which comes from a study done in 2007, is that a lot of people are not diagnosed and they end up in nursing homes with diagnosis often of Alzheimer's dementia. In this particular paper, it was found that up to 14% of patients might have had MPH, which wasn't diagnosed early enough. They looked at the medical records of elderly people in the States admitted to nursing homes. So if we extrapolate this data to the population of Ontario, assuming that we are at this point at 2.2 million seniors living in Ontario, we can possibly say that at this point, 11,000 people are displaying symptoms and signs of normal pressure hydrocephalus, or they're about to have this problem. And again, because of age population and the aging of the population, this number could probably be much higher in the near future. So how about the therapy? Dr. Tang-Wai already mentioned how we diagnose patients. We want to see if there is an improvement after the TAP test, because this tells us that the patient might get better after brain surgery. So the TAP test is this large volume lumbar puncture that you heard of. And when we are confident that the diagnosis is correct and that the patient can improve, we send our patients to our neurosurgeons. I'll tell you more about them in a second. The neurosurgeons do an excellent job inserting a shunt in the brain of patients. So this shunt is meant to drain this excessive fluid from these chambers that we call ventricles, and the fluid is shunted and is delivered to the abdomen of the patient. And because of this constant drainage, you can see results like in this man. This is the same patient a year after the shunt, and as you can tell, it was diagnosed early enough, and there was a complete, almost complete, I would say, resolution of the problems that he had before surgery. The other thing that we do, which is pretty unique, is that the neurologist, particularly myself, is in charge of programming the valves. We use special valves that can be adjusted from outside using this technology that you see in the video, so that we can drain exactly what's needed. Because if we don't drain enough water, enough fluid, the patient doesn't improve. But if we do too much, the patient might have a complication called subdural hematoma. So we want to slowly and gently increase the amount of fluid that is drained over time until we have a good outcome. This is what makes us special. As you heard already, we are the first interdisciplinary clinic of this kind. meaning that there are a number of people, of professionals with different expertise all around patients with suspected MPH. There is myself in charge of the movement disorder part, particularly gait, as you've seen already. There's Dr. Tang-Wai addressing cognition and behavior of this patient. There's Dr. Tartaglia, who assesses the fluid, because we remove fluid from the brain of these patients and the spine of these patients. So we have access to biomarkers, and this is mainly done for research purposes. And finally, we have an incredible team of 4 neurosurgeons led by Dr. Zade, and they are extremely helpful, and they can actually see our patients very soon, and in few months get the shunt done, and then the patient is sent back to us for shunt adjustments and follow-up of the patient over time. And all we do is also possible thanks to the support of our assistants and also the many fellows and residents who happen to work with us to learn from us, but they're also very instrumental in doing what we do. And now I want you to listen to the story of one of our patients who was featured a couple of years ago on national TV in Canada.
Imagine struggling to stand, walk, and suffering from memory loss, all classic symptoms of Parkinson's and dementia. But it may be a different disease altogether. CTV's medical specialist, Avis Favreau, with more on the confusion and the cure.
If you watch carefully, you'll see why John Searle was told he had Parkinson's and also signs of early dementia.
I listened to him repeatedly saying, I don't know how much more of this I can take. And it broke my heart.
But instead of worsening,
try again, a little faster.
This is John today.
Yeah.
That diagnosis was wrong. He had something called normal pressure hydrocephalus, or NPH.
The story of John was featured by many other channels. For example, here you see the BBC. And I was impressed by this because NPH is in theory a known condition. It's present everywhere in the world. There are many doctors dealing with it, but clearly more needs to be done. And I will imagine that not all doctors are familiar with this condition, and not even patients often know about it. So this is probably why his story captured the attention of so many people worldwide. And like him, there are many others, and we're hoping to help them all as much as possible. And for this reason, as you heard already, you'll hear the experience of another patient of ours later on today. With this, I want to thank you all for your attention, and Christian, back to you.
Thanks, Dr. Fasano, and to Dr. Tang-Wai for this remarkable story of your groundbreaking efforts to create the first in Canada interdisciplinary NPH clinic. And don't go away, guys. I want to include you in our next discussion with our special guest. But first, a quick reminder to you in the audience, if you have a question for Alfonso or David, please go to the Slido page. The link's at the bottom of this live stream window. Click or type in the event code, which is hashtag MDS series, and send us your question. Remember, for privacy reasons, we can't answer anything of a personal medical nature. Okay, let's bring in our special guest, a patient treated at UHN for NPH. Welcome, Mr. Alan Lerman. Thank you for being with us, Alan. You're on mute, Alan.
Yeah. Okay. Thank you very much.
Nice to have you with us. Yeah, great to have you. Alan, take us back to 2014. That's when you started experiencing these symptoms, which our doctors have talked about in terms of mobility. You also experienced vertigo developing as well. How is this affecting you in your lifestyle?
Well, it's the walking and mobility that really gets me because I can't do what I used to do. Back in 2014, I was able to walk. We go to Florida every winter. I was able to walk 4 miles a day, and couldn't do that by 2015. Early 2015, I was down to not doing much. And
I'm curious, in those early days or weeks or even months, what were you told this could be?
Well, when I came back to Toronto, I was sort of diagnosed I have neuropathy, and I should try with a trainer to improve my my gait, but that didn't work. And then I was developing urinary problems where I had urgencies and great need to go. And from there, we just sort of were moving around. Never heard about NPH. I knew nothing about it. The first time I heard about it, I developed vertigo in early 2015. I went to Sunnybrook for a scan and what have you. And one of the residents said, "You might look at the NPH." So we didn't know what it was. We started investigating and then proceeded from there to try and figure it out if maybe we had NPH, because cognitively I was still fine. I just couldn't walk well.
And that's around in 2015, after this diagnostic, that's when you were brought into the picture, right, Dr. Tang-Wai? I understand you, Alan was referred to you, and I'm curious, what did you see and what was your assessment?
So very much what Mr. Lerman has already said. There was a problem with walking. There was an element on story of maybe a neuropathy, but the overall picture, the scans were highly suggestive of hydrocephalus, and we went to proceed as such and test for it.
And Alan, what did you know about like how this would affect you, your future, in terms of lifestyle again, if it wasn't treated?
Well, my walking ability would be bad. The urinary problems would still continue to be bad, and probably a decline in the cognitive function. Fortunately, that hasn't happened because we were able to get the lumbar punched on, and we decided that's what it was. So.
And Dr. Tang-Wai, so what was the treatment then?
We did do a large volume spinal tap that we had discussed earlier, and there was an improvement in the walking by several seconds. So we measured it by time, and then referred you to a surgeon after that, who gratefully put a shunt in.
And Alan, where do you think you'd be today if you hadn't had these treatments?
Oh, I don't even want to think about it because I wouldn't be mobile at all. I'd be stuck in a wheelchair or doing something else. So it astounds me as to what can be done if you get the right diagnosis.
Well, we appreciate you expressing your story today and sharing your experience. I want to bring in both Dr. Tang-Wai and Dr. Fasano here, because I'm curious about the origins of the clinic, because it is something that's been known about in medical circles, but there really was no specialty clinic or anything like that in existence. So how did you guys mount the clinic?
Maybe I can start. My personal interest was understanding why this condition causes gait disorders, because gait and balance problems are major drivers of poor quality of life. And this is very true for any condition, particularly, so not just movement disorders like classic conditions like Parkinson's disease, but if you were to ask Parkinson's disease patients, the tremor and other signs that perhaps are more known to the general public are not that important. What people really want to do is being able to go to restaurants, to spend time with families, to walk, to go for a walk outside. So gait and balance problems are really important, and that's why I dedicated my research to these problems. And in doing so, I always wondered, okay, why is this happening to NPH patients too? And when I joined Toronto in 2013, there was no program, but I know that David and other colleagues of his involved in dementia were already discussing how it was possible to treat NPH patients, perhaps sending patients to other hospitals. But Toronto Western is a neuroscience center, so we identified clearly that this should have been one of our priorities. So to have in-house a system to take care of these patients, not only clinically, but also to understand the condition, to teach the condition, because when I was a resident, nobody ever told me about it. And we want our residents, our fellows, to go back home and take care of their patients, also thanks to what we are teaching them and what we're learning ourselves day by day with our patients. Don't know if David wants to add anything to this.
Yeah, sure. Thanks, Alfonso. Yeah, we were doing it separately. And it was inefficient and was time consuming and delayed treatment, delayed diagnosis. So we did decide, well, this is ridiculous. Let's do it so that we can both see an individual as quickly as we can, make the assessment, get the right diagnosis, learn off of people that we have treated and seen, learned off each other, because we now have a better appreciation from, at least I do, from a gait disorder. Making it a nice slick. We could not have done it without neurosurgery and Dr. Zadeh. It's a major part. Without the third pillar of our clinic, we couldn't move either. So it was fortuitous that we all got together. We all hammered out a great plan.
I'm wondering, as you were coalescing and pooling your talents together to make this clinic, I'm just curious if there was any challenges or obstacles to making this a reality.
Many challenges. Simply the fact that our job description, the reason why we were working at Toronto Western back then, didn't include MPH. In a way, we started doing MPH in our spare time almost. What back then it wasn't clear to us, and I'm sure I'm talking also for David, is that it wasn't clear that there was such a huge need for MPH care in the community. And that's something we happened to learn the hard way, because after we started the program and started taking care of a few patients, more and more patients were sent to us. And that's one of the biggest challenges at the moment. So to have enough manpower, enough support, enough dedicated time to assess patients with a possible MPH. As you heard from David's talk, diagnosis is not simple, because yes, we start from imaging, but the clinical features are pretty common in this population. Everybody at a certain age has urinary frequency or urinary incontinence or some problems with mobility or some problem with memory. So understanding what's caused by MPH and what's instead just coming from aging is not that trivial. So it is a long process. We don't want to do brain surgery. We don't want to recommend brain surgery if it's not needed. Also because we're dealing with seniors, so elderly population, and obviously there are risks associated with the brain operation. So it is a process. It's not an easy diagnosis to make. And like I said already, we were overwhelmed by the number of referrals, and this has been, to me at least, the biggest challenge.
Yeah, the scope and scale actually is striking in terms of in seniors, and especially as you get older, going from 1 in 200 Ontarians over 60 to 1 in 10 by the time you reach 80. Talk to us about your vision then for the future of this MPH clinic at UHN and Toronto Western.
Well, I been discussing this in length with all the players, and I think we did a great job in streamlining the process, because putting ourselves in the shoes of patients with mobility issues, often coming from far, we wanted to have everything done in 2 days. Sometimes even the assessment with the neurosurgeon can be done on the same day, in theory. So moving forward, we'll probably need to have dedicated time, dedicated personnel, so that we could possibly do this on a regular basis more and more often, so that we could really take care of the many referrals that we're receiving. At the moment, we're receiving a lot of referrals, and there's already some triaging of the referral up front. So we want to see the images before, we want to see the clinical story. There's a common misconception, and I'm sure there will be questions about it, is that any person with memory problems or with gait problems should be assessed for normal pressure hydrocephalus. But that's not true. We start from the picture. We want to see a certain type of MRI. So we process the request up front. And even doing so, we're still far behind. So the future will be a more streamlined process with more resources to take care of this many Ontarians requiring our help.
And from what you're saying also in terms of the percentage or how it can be misdiagnosed, it can be masked by other conditions. How important is education of healthcare workers as well as patient going to be going forward?
It's extremely important. This is something I learned over the years dealing with another condition, Parkinson's disease, and the treatment of Parkinson's disease with deep brain stimulation. We don't go around looking for patients. We are the tertiary center, we are the expert, but if the referring neurologist is not aware of what we can offer, and especially is not aware of the time window that is so important, we are not getting the right referrals. So it's an important part of the process to be able to communicate with a network of physicians and even general practitioners in the community, so that they know that waiting doesn't pay off, because NPH, it is potentially treatable, but especially after years, it's not completely reversible, because over the years, the brain sustains damage. So people don't need to wait, because we're already making them wait, unfortunately, with our wait times. So the referring neurologists or other physicians need to be aware of the complexity of the diagnosis and have a high rate of suspicion that when there is a possibility of NPH, they send the patient to us, and we try our best to assess them as soon as possible.
Dr. Tang-Wai, did you want to weigh in?
Yeah, so we do our best to educate as many physicians out there. Dr. Fasano, I've already given presentations. I've presented to family physicians with just to present just key features, things that you really should do before considering referring to us. One is get a scan. I mean, that is key. If those large if the ventricles are not large at all, and we don't see the features, this is not NPH. It's probably something else. It's the details. So it's as much as we could say it's urine and thinking and walking difficulties, even with each one of those, there are certain details that we're looking for. There are certain aspects that makes it an NPH picture and not maybe there's Alzheimer's or maybe there is a bit more Parkinson's. So that education has to be there as well. And once all of that, if we can send that message out to as many people as possible, yeah, we're hoping that this gets picked up and it's readily identifiable. That's what our goal is going to be. And we learn what is the best test, maybe there's something better out there as well.
So given demand, given the anticipated growth in this condition because of an aging population, what's it going to take you guys to get there in terms of scaling up your clinic?
Well, funding, which should be, that's always the answer, right? But it's true, because clearly we have the knowledge, I would say, the dedication. Hopefully this is what people at home can also see. But funding is a crucial part, because this requires nurse practitioners, social workers, even the material, to look at the lab results and analyze the CSF, so the liquid of the patient. So there's a lot of there are a lot of moving parts, and unfortunately, some of them are pretty expensive. So at the moment, we are basically outsourcing and trying to steal here and there people who are willing to help, even though their practice is not focused on NPH. So ideally, we should have enough funding through Ministry of Health, through donors, so that we can really build this program with a dedicated team of people supporting it, not just trying to help each other to make it work while we're busy doing something else. Don't know if David has some other comment to that to add to the wish list.
Well, that is a lot of my wish list too. So that's great. And we need time. And this allows us to give us the time to develop, to think more, to come up with some better treatment. That's what it'll allow us to do.
Given, our audience includes some potential donors, do you guys have an elevator pitch you could give us?
Well, no. What can I say? I can simply say I'm not good at slogan, but I can only say that NPH is preventable, it is treatable, and if not treated, leads to early death. It's been shown by studies. So engagement of donors in this will make a huge difference to many people and their family. So we're not talking about improving quality of life. We are also talking about improving quantity of life, lifespan. People die earlier if not treated.
Fantastic. Well, listen, you two have been champions of this for the last several years. It's great to have you on the show. Stick around now because I want to move on to our audience questions today. If we want to throw up the Slido page and let's take a look at what's out there. First up, and Alfonso and David, I'll let you arbitrate who's best to take these questions, if you don't mind. Why does MPH occur? Is there prevention we can focus on early in life?
Maybe I can take this one because this is a fascinating part that personally I didn't know about MPH, and I've happened to learn more and more over time. MPH is not a single disease. It is a syndrome. It comes from many different reasons. Sometimes it's clearly identifiable, the cause, and this could have been a meningitis, trauma, some actually people affected by concussion in sport might develop over the years MPH. So in these cases, we know why it happened. But in many others, and I would say in the majority of the patients we see, the cause is not clear. This is what we call idiopathic normal pressure hydrocephalus. Now, it turns out that if we measure the head size of these people, their head is a bit bigger. So this makes us believe that MPH is something that starts many years before, even when they were babies, maybe a trauma or something happened while they were even in utero. And with time, this buildup of fluid grows and the brain is less capable of compensating because of the aging processes that are occurring at the same time because of age. So it's really coming from many different factors, many of which are not known. But we're learning more and more these days, and we also know that there are genetic reasons for MPH. Some genes, when mutated, can predispose people to MPH. So we're really understanding more and more as we really dig into this condition day by day. And in terms of prevention, and that's the one thing that impressed me, we always talk about sleep quality and how important it is to have a good sleep to prevent the onset of neurodegenerative conditions. The same applies to normal pressure hydrocephalus, because it turns out that during night, when we sleep, this fluid in our brain does its job, which is removing toxins from the brain. So if sleep is not good, and more importantly, if there's sleep apneas, which are very common in MPH patients, there's always a constant increase of pressure in the skull, in the brain, so that there's a traffic jam of this fluid that creates even more problems. So exercising, losing weight, sleeping well, these are all high blood pressure. These are all conditions that can be treated early on and possibly reduce the occurrence of MPH.
Next question from Arthur Mans. How does one tell the difference between Parkinson's disease and MPH? What are the early warning signs for MPH? Is there an early test for Parkinson's? Thank you.
I can probably take this one too because it relates to Parkinson's, while the next one I see will be perfect for David. Parkinson's patients have early signs, which are not well known sometimes. These are signs like acting your own dreams. So when you dream at night, you move, you talk, or missing the sense of smell, or constipation. These are not seen in MPH. And more importantly, MPH, yes, presents with a motor problem, but the motor problem is affecting the legs, so walking and balance. In Parkinson's, at onset, usually it's not that. It's usually a rest tremor on one side or some slowness on the upper part of the body, immobile facial expression. So it's really different than what we see in MPH. What we see in MPH can be seen in Parkinson's, but many years later. Problems with walking in particular is not seen right away in Parkinson's. It takes years to develop. And the same applies to urinary urgency. Instead, in MPH, these problems are much earlier, and that helps distinguishing the two conditions.
Very good. From Liz, for Dr. Tang-Wai, what are the early detectors to MPH that would differ from Alzheimer's?
Good question. Very similar to what Dr. Fasano has already said. The first symptom of NPH is almost always the walking change before any thinking change. So that's one early detector. And if you look at the thinking problem itself in NPH versus Alzheimer's, it's different. So in Alzheimer's disease, and typical classic Alzheimer's disease, is a short-term memory problem where there's rapid forgetting. So you tell someone some fact or that they have an appointment, and literally within minutes, it's forgotten and they repeat themselves. The thinking difficulty in normal pressure hydrocephalus is not short-term. It's actually pretty rare for that to occur. It's more of a concentration issue. It could be a slowness. It could be difficulties with multitasking. It could be a reticence to do a particular project. That doesn't always have, it's not very frequent to see that in Alzheimer's disease. Unfortunately, that type of memory or thinking difficulty is actually seen in a lot of disorders, including Parkinson's disease as well. So even drilling down into that detail, well, okay, is it with a walking problem? Is it not with the walking problem? Are there other signs of Parkinson's symptoms in here? And is that balance of that triaging of that detail that we're trying to sort out? Is it hydrocephalus? Is it Alzheimer's? Is it the earliest presentation or not? And that's that balance. And it's from a urinary perspective, that's the third symptom of NPH. That's extremely rare that is going to be the first presentation. In fact, it is. We're often not thinking of NPH first. We're going to think of something totally different. Mm-hmm. So that's how we would look at this case.
From Mika, given that NPH is so under-recognized, how would a patient advocate to be tested for NPH? How can a patient or caregiver push for additional testing if another diagnosis, example, atypical Parkinson's, MSA, has already been given? David, do you want to take that one?
Yes, I think the key part of determining if someone has NPH is imaging, the MRI or CT scan. If it doesn't show or demonstrate those large ventricles, those large black spaces, it's not NPH.
So that's a key anchor factor.
That is actually a must. Without that imaging, it's not going to be that. So that's what, if anyone is ever concerned about the possibility, the way I feel it, and probably Dr. Fasano also, is everyone should get at least a scan, see what's going on. And there are features on the scan that may help differentiate other disorders like MSA or Alzheimer's disease. But for NPH, there must be large ventricles.
Alfonso, anything to add?
No. I agree entirely with Dave, of course.
Okay. Does NPH affect people under the age of 60?
Yes, if we're talking about NPH caused by what I mentioned before, trauma, hemorrhages in the brain, these are called secondary NPH. So it can be seen at any age, obviously, because here the problem is more generally an impaired absorption of the fluid that the brain produces, and it can come from different reasons. The NPH that we take care of most of the time, as I said already, is the idiopathic form. It's the one that happens over the years in elderly patients. And this has to be, by definition, in people older than 60. That's part of the diagnostic criteria, but rarely it's in that age range. Actually, it's most of the time around the age of 70 that we see this happening.
I see. Okay. From Tina, can the treatments for NPH help patients with MSA, especially with balance issues? Thank you.
I can take this one very quickly to say that unfortunately, MSA has no real treatment. And unfortunately, shunting patients with MSA not only won't be beneficial, but it can also be dangerous because the brain of patients with MSA or multiple system atrophy is pretty frail. So you don't want to do an operation unless it's really needed. And we know that it will not work. In case you wonder, there have been studies in the past. We know that in people with NPH, when we analyze the brain of people with a diagnosis of NPH, we can find signs of Alzheimer's disease, which is pretty common at a certain age. For this reason, there have been also trials shunting patients with pure Alzheimer's disease without signs of big ventricles. And these trials have been negative. So we know that in order to have a benefit from shunt, you really need to have NPH. And NPH is not just enough. You need to have NPH with signs that an intervention is causing some improvement. That's why we do the TAP test. We want to see that some of the signs are reversible, because if someone has MPH for 20 years, even though the diagnosis is still MPH, treating the patient will not provide any benefit. So yes, it works only in MPH patients, not in other conditions. And even in MPH patients, has to be done early enough. Otherwise, there's no improvement anyways.
From Liz, if an 80-year-old had a shunt implanted for MPH, what's the shelf life of the shunt in their head?
Dave, you want to say something about it? Or?
No, go ahead. I mean, it should last for as long as it's there without any complication. It should last for the lifetime of this 80-year-old. They're pretty robust. If you're talking about a 5-year-old, that's a totally different question. But in the population that we see, the shelf life of the shunt is not an issue.
Very good. A timely intervention to MPH seemed to be really cost effective. Why aren't there other clinics like this in Ontario?
That's a great question. It's a good question for politicians, maybe.
Yes.
It's true. I'm Italian. I've been practicing in different geographies, not just in Italy, but also in other countries. And I should say that I'm proud to be practicing medicine in Canada, because really healthcare has to be public. And when something is public, cost-effective analysis makes the difference, because you don't want to waste money intervening when it's too late. You want to prevent people from having problems so that you can save money and use this money for something else. So prevention is key. And in this regard, an early diagnosis of MPH, an early treatment of MPH is going to make us save money. So taxpayers, will be, in theory, paying less taxes in theory, right? Falling is a big problem in elderly, and MPH is a potentially reversible cause for falling. Falling is associated with trauma, fractures, hospitalization, death. So this question is absolutely spot on. There are other examples of analysis that led Ministry of Health to the decision of implementing more and more of certain therapies. An example is deep brain stimulation for Parkinson's disease. In 2005, Ontario decided that DBS needs to be used more often because it's cost effective. I think that the time is now come for this type of discussion and analysis also for MPH.
Absolutely. Great question. Who can diagnose the patient with MPH and how? Can family doctor diagnose MPH? Can Parkinson's diagnosis from approximately 15 years ago be, in fact, MPH?
I think I'll tackle the first two, and I'll let Alfonso do the last part of it. But so it's a good question, and it depends on your point of view. Let me tackle the family doctor first. I think it's important that the family doctor be aware that there is something called normal pressure hydrocephalus. Mm-hmm. That be aware that there are some symptoms, may not know the details behind it, but if they see an individual who has some walking, some thinking, get a scan. That's priority. Get the scan. And if the report says there's large ventricles as a concern, then at that point, I don't want the family doctor. It should be a neurologist or a specialized clinic to then get involved with that. Right. Because then we can go after the details. Are there mimickers? Is there something else going on? So I think it should be structured in that particular fashion. And I'll ask Dr. Fasano to do the Parkinson for 15 some odd years.
That's an easy one, because if someone has a disease for so long, the diagnosis is clear. Parkinson's disease, after years and years, has specific features like involuntary movements caused by medications, fluctuations of the motor conditions. So this is impossible to be seen in MPH. So the question might arise initially when someone is diagnosed with Parkinson's, maybe, but 15 years into the disease, you know that you're dealing with Parkinson's disease. It can't be a misdiagnosis.
Very helpful. Thank you. What is wait time now if you have been referred?
Key question. This is an embarrassing question for us. And that's why we're also very happy to know that the foundation wanted us to present our program, because we need help. The wait time at the moment is close to 3 years. And that's embarrassing. And part of it is COVID, but we should not always blame COVID. Part of it is, it's our own success. David always say we are victims of our own success because we did well, we helped patients, and the word got out, and more people are being referred to us. And at the moment, it's very difficult for us to process patients. And we truly believe that an early intervention is needed. Yet at the same time, we are dealing with such an embarrassing wait time.
Yeah, and let me add to it. Our referrals aren't just coming from GTA, it's coming from across the province. So our success has gone beyond the borders of our city, and other people have now lodged in and been referring. So that has also contributed to our wait time as well.
Well, this is great timing also in terms of having this live stream and having you guys on. And also there are politicians coming to your door for the next few weeks. So maybe this is a question for them. Next question. Since it's treatable, once MPH is diagnosed properly, can you reverse the symptoms? How soon do you have to diagnose to be back to normal? This is what percentage of life can you get back?
Well, this is something that can be difficult to predict sometimes. We look at a number of features. Obviously, if someone only has MPH and there are no other medical conditions like, history of smoking, hypertension, diabetes, so all the classic problems that can affect brain functioning. And if the same person is diagnosed early enough, then a good proportion of the problems that this person is having can improve. There are possible ways to understand that. And it's not just the time elapsed from diagnosis to therapy, but it's also looking at the scans. We've been talking about the importance of CAT scans and MRI. And in this case, MRI in particular, because the MRI can actually let us see the effect of the pressure in these ventricles, because we can see all around the ventricles something we call hyperintensity, so white spots all around the ventricles, which is basically damage that has occurred. And the more white spots we see around the brain, around the ventricles, the more we know that even releasing the pressure is not going to give neurons back to this person. So that's a possible way to trying to predict the back to normal question. Don't know if David wants to add something else to this.
Yeah, and because we are dealing with predominantly an elderly population, people often have more than one problem. So they have arthritis, which can contribute to the walking difficulty. If you're a guy, you have prostate problems that can contribute to the urinary issues. People have what we call vascular disease in the brain, which also complicates the look of hydrocephalus of NPH. As Dr. Fasano said, there's a quarter of the people who have Alzheimer's that pathology. So to say that back to normal, it is dependent upon the single person. What do they have? Are there other factors involved with this? We can easily say, if you improve on the TAP test, yes, your walking will improve. That we can say. We can say likely the peeing will definitely improve. The thinking will improve. Back to normal is harder as a question to answer. Improvement, yes.
Fair enough. Next question. Is MPH prevalent around the world? Sounds like the clinic at UHN is groundbreaking. Are any other docs doing this work?
Oh, yes, there are many. In North Europe in particular, in Canada, there's another big center, but it's mainly under the care of a neurosurgeon, Dr. Hamilton in Calgary. So there are many doctors also in the States interested in MPH. What we're adding to this is our approach, which, as you see, puts the patients at the center with all these different people with different expertise around the patient. So to answer the question in short, there are many doctors, we are learning from them, but we're also contributing, even though we started not a long time ago. Now, many people worldwide are looking at our models and trying to see how to implement, particularly this attention to the patient coming from the neurologist. So the neurologists are used to treat patients chronically. So we're okay with diagnosing them, to perform a differential diagnosis, to take care of them after surgery. So it's the same model seen for other conditions like Parkinson's. And that's the added value that wasn't present elsewhere in the world. And we are now inspiring to some extent these other doctors who have been there doing their great job and teaching the scientific community about NPH for years, well before us.
Yeah. And I just want to add one thing, maybe to embarrass Dr. Fasano. Dr. Fasano is also the lead of an international committee on NPH and part of the Movement Disorder Society. So there is this community to learn off each other. So sorry, Alfonso, I have to add that.
Thank you,
No,
Dave.
that's terrific. It shows again how we are leading in terms of intellectual capacity, research capacity, as well as the clinic and treatment. So that's great. Fascinating presentation. Thank you to these brilliant docs who are advocating for this work. 14% of seniors in retirement homes with NPH is incredibly high. I think that was a US stat, but likely transferable here. Do you suspect an increase in prevalence as the population ages? We need to educate public and healthcare workers on what to look for.
Yeah, the 14% is concerning. I would agree with that. It's an old study from 2007, only looking at the American situation in a couple of nursing homes, just as a sample to understand what's the situation. I don't think that in Canada the number is so high. I would hope at least, but I'm sure that some people have been having NPH all this time, but because they weren't treated by neurologists or because nobody did a scan, the NPH part was missing. And this highlights two parts. The first one, we've been saying this over and over, it's important if you want to advocate for yourself, that you ask your doctors to simply have a CAT scan or an MRI of your brain. You don't have to do it every year, just you need to have one when you have neurological problems of this type. And the second, unfortunately, is the lack of neurologists, because oftentimes, especially in poorly served areas of Ontario, there are not enough neurologists, and family doctor needs to take care of patients with dementia or with Parkinson's or with gait problems. And this makes the diagnosis more difficult, because obviously family doctors, they're doing what they can, but they are not trained to take care of these complexities. So that's the concerning part specific to the Ontarian situation.
Our last question today from Frank. What if the patient measured value of ventricle size has a borderline to value for NPH? Is this value monitored after a shunt has been applied to a patient?
Dave, you want to take this, or you want me to?
No, you can follow up, but the after a shunt has been placed, sometimes often the ventricle size don't change, and we see that. So we don't measure the response based on a radiological, i.e. MRI or CT, but what does the person do? Are they walking better? Is their thinking better? Is their peeing better? So that's how we monitor someone after a shunt is placed. I don't know, Alfonso, if you want to add more to that.
No, absolutely.
Terrific, guys. Really appreciate it. We've come to the end of our time today, almost bang on to the minute. I want to thank all of our guests today, starting with I keep calling you Dr. Alan Lerman, Mr. Alan Lerman, an NPH patient at UHN. Thank you so much, Alan, for taking the time today to share your story. Dr. Tony Lang, he's director of the Edmund J. Safra program in Parkinson's disease, the Morton and Gloria Schulman Movement Disorder Clinic, and the Rossi Progressive Nuclear Palsy Center. Dr. Alfonso Fasano, staff neurologist at the Edmund J. Safra program in Parkinson's disease and the Morton and Gloria Schulman Movement Disorders Clinic at Toronto Western Hospital, clinician investigator at the Krembil Brain Institute, and the chair in neuromodulation and multidisciplinary care at UHN and the University of Toronto. Thanks so much for joining us with your insights today, Dr. Fasano.
Thank you.
And Dr. David Tang-Wai, co-director of UHN's Memory Clinic, clinician investigator at the Krembil Neuroscience Center, and associate professor neurology and geriatric medicine at the University of Toronto, and department division director of neurology for the University of Toronto. Thank you to you, David. And a big thank you, of course, to our audience out there joining us today. We'll be returning with another edition of the Movement Disorders virtual speaker series this fall. Keep an eye on your email inbox. This event has been recorded and will be up on the UHN Foundation YouTube page shortly after this live stream is over. And finally, if you are moved to donate to the Movement Disorders Research Program and the work of these fine gentlemen, the groundbreaking work that they're doing to improve patient care and treatment, please, you'll find a link at the bottom of the page of the streaming window that will direct you to our donation page. Your support is very much appreciated. Thanks, everyone. Stay safe. We'll see you again.